This patient was referred to me for evaluation possible endodontic retreatment of teeth number 30 and 31. Take a look here. According to the patient, the crowns are 5-6 years old. They were done here in the USA. The root canals were done in Russia many years ago. And she complained of swelling in the area of number 30 and 31, swelling that would come and go. Okay, so take a look here. Look at tooth number 30. Let's start from the top. So there's a crown on the tooth here, as you can see, some kind of a metal buildup. These are Russian root canals, so it's the material they use is Russian red, paste material, okay? Perhaps open margin there. And as you can see, the kind of root canal, as I said, that they do in Russia, periapical lucency here. Also, you can see there's a furcation involvement as well. This tooth probed 2 to 3 millimeters all around. Percussion tender, palpation slightly tender. And again, we went over the radiograph. I'll show you the clinical picture of the teeth also. But let's look at tooth number 31 now. Again, crown, open margin here, Russian style root canal, furcation involvement, lentula broken here, and another file broken there. But as you can see, there is no periapical lucency on this tooth. Definitely furcation though. All right. So let me show you the clinical photo of these two teeth. But before I do that, number 31, percussion tender, palpation tender, probing mid-buccal was 8 to 9 millimeters. And let's now look at the clinical photo. All right, so let's look at tooth number 30. Again, you need to be able to, when you look at the tooth clinically, you need to be able to get all of this information. Pay attention to everything that you see. So take a look here. That's tooth number 30. There's a crown on the tooth. What's going on here? There was severe buccal abfraction associated with tooth number 30. What will that mean when you want to redo this root canal? That means that this wall, the buccal wall associated with the mesiobuccal canal and distal buccal canal, that wall, that buccal wall is very, very thin. Very thin now. Very thin now on the coronal part of the canal. So that means that you need to really be careful. You can't over-instrument coronally. You can't over-flare or over-taper these canals, mesiobuccal and distal buccal canals on the coronal part of them too much. You can't flare coronally too much. Okay, so that's one thing that this clinical examination will tell you. Now look at tooth number 31. You can see there is a sinus tract right there, and as I said, mid-buccal probed 8 to 9 millimeters. All right. So I went over her options with her. This looks like perio and with 8-9 millimeter pocket. And what's going on with the endo? This tooth has a very poor prognosis. So patient is welcome to go see a periodontist, but as I said, 8-9 millimeter pocket there, and furcation, not that much furcation, bone loss and broken files and lentula, all that stuff, Russian red, obturation, very poor prognosis. So patient decided to go ahead and extract this tooth. Regarding tooth number 30, went over her options with her. She can choose to try to see if we can save the tooth for her. Very guarded prognosis. Furcation, Russian red, obturation, calcification, infection. This tooth has many things wrong for it. Or she can choose to extract it. Patient decided that she wanted to try redoing the root canal. Next case was this 82-year-old patient who was referred to me by her general dentist. The general dentist is a very good friend of mine, and he does 99% of his own root canals. Every time I see his name on my schedule, I know it's a tough root canal. And as you can see, he's a smart dentist, because he doesn't spend time on these root canals that he sees that are very tough. He spends his time on root canals that he's comfortable with, are easier for him and comfortable for him at his level. So he sends me these types of root canals. Anyways, 82-year-old, as you can see, periapical here and there, and patient has symptoms. As you can see, there is partial calcification of the canals too. There's no pulp chamber. So again, I went over options with the patient. Root canal with guarded prognosis, no promise or guarantees. That root canal would clear up your infection, or you can choose to extract the tooth, and patient couldn't decide, so I gave her a day to think about it. Next consult was tooth number 2. Tooth was being prepped for a crown. There's a temporary crown on it, and patient says that his dentist told him that she was too close to hitting very close to hitting the nerve, so he needed a root canal. So patient came to see me for a consultation. I examined the tooth, slightly tender to percussion, palpation within normal limits, probings 2 to 4 millimeters all around, and as you can see, yes, looks like the crown prep buildup kind of close to the nerve. So this would be considered irreversible pulpitis now. So with acute apical periodontitis. So we went ahead and went over options. Tooth number 2, upper right second molar. Either we can go ahead and do the root canal for you or extract, and patient decided to go ahead with the root canal. So we scheduled him to come back for the root canal. This is my first treatment of the day that we're going to be starting in a few minutes. There's crown on the tooth, as you can see, partially calcified canals, and periapical lucency. Patient has symptoms, so we scheduled him to come back and a few days ago, and he's here now for the root canal. So we're going to go ahead and go through the crown and do what we need to do. Looks like MB1, MB2 here, as you can see, and palatal and distal buccal is right there. So we're going to be going in to do this root canal in a few minutes. I take the measurement, so you ready? Go ahead. All right, so tooth number 15, the probings were 2 to 3 millimeters. Let's probe the wisdom tooth number 16, and you walk the probe and take a look here. I'm down to right now 9-10 millimeters on the wisdom tooth. And it just sinks right in, right there. Okay, very good. Thank you. This patient was referred to me for endodontic treatment of tooth number 30. Due to his medical history, he cannot have extractions. So take a look here. So tooth number 30 is here, PFM crown. You need to take multiple angulation PAs, and the reason you need to take multiple angulation PAs is to open up the tooth and see hidden gems. Look at this angulation. You can see the recurrent decay, root decay, as a matter of fact, here. And take a look. What kind of anatomy is this? Put it in the comments. So, of course, we needed to go ahead and do the root canal for him. Went through the PFM crown, removed the decay here, rebuilt that wall temporarily. He's gonna need crown lengthening there, and build up in a crown, of course. But again, put it in the comment what kind of root canal anatomy or root anatomy does this tooth have. So take a look here. So you're thinking 2 mesials and 2 distals, right? Okay, take a look. Three mesial canals, and of course 2 distals. Everything went great. As you can see, we went ahead and Temporize the tooth and refer the patient back to his dentist for the permanent restoration.